So basically what we discussed from last time, either true aneurysmal dilation or actually just the tumor which was involving portion of bowel, and then it looked like lymphoma, like aneurysmal dilation. So we saw a case of GIST like this last time. And this is a case of colon, which looks like aneurysmal dilated. And this turned out to be adenocarcinoma. I'm sorry, I just have a still image. I'm unable to find that case, but when I find, I can share links with you. But right now, I just have a single image. I also found out the article which describes this.
Yashant, I have a question about your case. Do you happen to know if it was mucinous? Because it looks a little low density. I'm just curious.
I don't think it was mucinous, but
Okay.
I can double check the histology.
Okay, no worries, no rush. I just, yeah, that's really rare to see it aneurysmal like that. Or at least I haven't seen it much. But go ahead with the article.
And 1 second. So that's the article. And in this article, they describe two cases of aneurysmal dilation of colon. And both of these were adenocarcinoma. Let's skip to the imaging. So that's case number 1, and it is aneurysmally dilated here. And that's another case in which this is massively dilated. And they do talk about that, lymphoma can be, while the suspicion of lymphoma would warrant a biopsy. So they did think about lymphoma, but then actually both the biopsies came out as adenocarcinoma.
Dr. Diffett.
So as we discussed last time, more than 95% of tumors that arise in colon are adenocarcinoma. So by stats, like it is statistics which is winning here rather than just the morphology.
I like that. I like that point. So like, even though it's classic for lymphoma, we should include adeno just because statistically it's going to be the most common. Nice. Thank you.
And it's just a follow-up. Just a follow-up on hereditary angioedema, which we discussed last time. So a couple of things which can give rise to, which can be triggers. So we did discuss that the trigger, the case was actually edema of the transverse colon, and the transverse colon had undergone colocolic intussusception, and the edema itself was acting as a lead point. So we did talk about the factors which can trigger it. So one of the factors that we addressed was stress, but other things like trauma, infection. So basically anything which is a stress can give rise to edema in HAE, which is hereditary angioneurotic edema. That's
it's called hereditary angioneurotic edema?
Yeah, HAE or just hereditary angioedema, one and the same thing.
Got it.
And then it has like multiple types, type 1, 2, 3.
Of course, for something we've never heard of before, there's now multiple subtypes. Very cool. Okay.
Okay. So this was a 28-year-old male patient who came in with upper GI bleeding. He had had a history of weight loss for the past 6 weeks. And on labs, they found he had very low hemoglobin. So I'm just going to scroll through the relevant sections of the imaging. And
there is some mass which is extending from third portion of duodenum to the retroperitoneum.
Right. So that's exactly right. So this was a single phase study. We didn't have much else. But yeah, this is kind of what we described as almost like an ulcerated mass. We weren't sure if it was within the duodenum or if it was pushing retroperitoneum, pushing into the duodenum. So what differentials would we have given, Yashant?
Sorry, what was the age? One more time.
28.
I would still think one's lymphoma.
Okay, that's kind of what we put. I mean, there were few other like circumferential soft tissue areas around the aorta, few other smaller retroperitoneal nodes. chest was clear, no lymph nodes up there. So this would have to be the only nodal station, so to say. Other thing we thought of was some kind of a small bowel. I know we were just talking about gist, so not the most circumscribed or that smooth effect, mass effect for gist, but some kind of tumor arising from the duodenum was the other differential.
Okay.
So anyway,
Can you show the aorta or the
Yeah.
vascular involvement again?
here.
Okay.
Because the way it is lifting at least the right common
Mhm.
iliac and the way it is bland enhancing, I would still think lymphoma.
Right. Quite homogeneous also, right? So anyway, because his hemoglobin was low and he had GI bleeding, they sent him to GI, who did an endoscopy and biopsy. And then surprisingly, this came back as some kind of germ cell tumor.
Oh, wow.
So
Ooh, wait,
What was
chicken
the gender?
mortem.
It was a
what?
man, you said.
It was a met. It was a node, I think. And then when we looked down in the testicle retrospectively, we hadn't covered this enough. But I'll show you the testicular ultrasound that was done after the endoscopy. Very unusual way for this to present. Yes. And I've just zoomed in on the ultrasound image. So here's the right testicle with this ill-defined hypoechoic mass, minimal vascularity. I don't have the correct zoom feature to show this on the non-Doppler image, but this was the only lesion we found. And then patient underwent orchiectomy, and sure enough, this came back as a testicular germ cell tumor. So learning point here was going back to the CT. Actually, there was an MR done in between. I can show that as well. Here. Yeah, so the learning point was in a young patient, never forget testicular tumors. They do love metastasizing to the retroperitoneal nodes. And this one was confusing because it looked a lot more infiltrative and it had a lot of mass effect on adjacent bowel that he presented with very unusual symptoms. And the primary itself was less than 2 centimeters. It was a very small nodule that patient had never been able to palpate. So we kind of stumbled upon the testicular cancer backwards. And I just wanted to share some teaching points. I found a good article on testicular germ cell tumors, which has undergone a new, I guess not new, but a relatively new nomenclature and classification by WHO. So there's now this term called germ cell neoplasia, GCNIS, germ cell neoplasia in situ. And so now they divide the testicular germ cell tumors into GCNIS related and non-GCNIS related. This is something I didn't know about. So the seminomas in this, they say, are the most common, of course, most radiation sensitive and chemosensitive. And some of these others, like these post-pubertal type of teratoma, is not necessarily very good, doesn't have very good sensitivity to chemo or radiation. So these may actually require surgery, like many other non-seminomatous germ cell tumors. And few other points they made in this was we normally measure lymph nodes in short axis, but in this they said you have to measure retroperitoneal nodes for testicular tumors in long axis because size again makes a difference. If they are larger than 1 centimeter, it's better to kind of remove the nodes via lymph node dissection. And if the nodes are smaller, you can treat them with chemo, and some of them may be chemo resistant, so it's better to remove them. Few other interesting entities they talked about was this choriocarcinoma syndrome, where there's a hepatic choriocarcinoma metastasis which just ruptured and it gave this appearance of alveolar hemorrhage in the adjacent lung because these are hypervascular lesions. And then this is something I'd never heard of also. This is called the growing teratoma syndrome, apparently, where you treat the primary lesion with an orchiectomy, but there's already a met to the retroperitoneum. And then the met starts growing, it starts to show calcifications, fat, etc. And this will not show any elevation of tumor markers, even though the original might have been like a yolk sac or whatever. And most of these also have to be surgically resected because they don't respond well to chemotherapy.
Rupa,
And in
that
this,
mature teratoma syndrome, it's usually like,
yes,
yeah, it's the mature part. That's why it's not responding to chemo.
yeah,
So even though it's like benign or mature, it's like it's actually growing. So
right. Because of the mass effect, I guess, is the problem more than the malignant potential, right?
yes.
Yeah. And then this was interesting. This was an undescended testicle which had a seminoma in it, which then became necrotic and infected. I would have every day called this some kind of an abscess in the abdomen. So it's a torsed seminoma which lost its vascularity and got infected. And then one
Wait, I
other
have a
thing.
question, Rupa.
Yeah,
Sorry, I keep it.
yeah,
That one, right? It says subsequent necrosis,
right.
but it doesn't say necessarily infection. I guess my point is sometimes I see a lot of air and it's just from
True,
like severe necrosis, not
true.
necessarily infection.
We see this with fibroids as well, right? And that's
Yep.
an area of struggle too, because those patients come back with fever, which is low grade, and then you don't know, is it from the embolization itself or this is infected? Clinical call, I guess. And
But in
then
this
one
case,
other
it says
thing,
they're necrosis.
this is just necrosis, yeah. Yeah, I meant to say I would have called it infection, not knowing any other history. So one thing they talked about also in this was testicular microlithiasis, and they said 50% of testicular germ cell tumors can be associated with microlithiasis, but then microlithiasis can be seen in asymptomatic men as well. And this article took me to another article where they actually gave dictation template for patients with microlithiasis. So if you don't have an intertesticular mass, it's not that worrisome. But if there is a testicular mass, that's always definitely worrisome. And if you have any of these risk factors, like a first degree relative, undescended testicle, or maldescended testicle, then microlithiasis does become significant. And then you have to suggest that these men get routine testicular self exam. So that's something interesting I found as far as microlithiasis. We see it many times, we don't know what to do with it. So I thought this was a cool template to add, to consider adding at least when we see these cases. That is one of
Super
my
helpful.
cases. Yes.
That's an
Wait,
interesting
Rupa.
case. Thanks for sharing.
Yeah, Rupa, I have one comment about the looking back in retrospect, like 28-year-old male with a retroperitoneal thing, like it fools us every time, but I feel like we should definitely think about the scrotum, like, you know, look at the
Correct.
testicle. And then
Correct.
I did have a case similar to yours where it was like encasing the vessels, like lifting the aorta, encasing the renal arteries and stuff. And so we were like, oh, definitely lymphoma. And it
Yeah.
turned out to be a seminoma. And so,
Yeah.
yeah, we just have to keep remembering they don't have to be like discrete nodal masses. They can be
Yeah.
encasing and infiltrative.
Aarti, I have one more image to show because we actually found a pelvic MR.
Yeah, sure.
They were looking for the scrotum, I think, and this again goes back to how ultrasound is such a more powerful modality to look at the scrotum retrospectively. Maybe this is that area. Looks a little different from the contralateral side. But they did this to look for any scrotal mass, and I don't think we called too much on it. But
Why did they do MR over ultrasound?
that's what I'm saying. I don't know why this
Oh,
was done.
sorry.
Yeah, but I think they got worried after they saw the biopsy and should have gone straight to ultrasound, where we didn't even pick this up on MR and the ultrasound so beautifully showed it. So I guess back to ACR appropriateness criteria.
Very nice.
I have a couple of things to add.
Yeah, cool.
One, testicular microlithiasis, yes, it can be worrisome and may not be worrisome all the time. Sometimes, again, it's not very common. Sometimes just isolated testicular microlithiasis can be associated with mediastinal germ cell tumor. And I can show you a case maybe next time of that. Second thing about testicular self-examination, although statistically it does not yield great results, but maybe on an individual level, it is great. And most importantly, we saw this case, so I found at least 2 articles on internet about same. And let's start with this. So here, do you see my screen? Do you guys
Yeah.
see my screen?
Yep.
Okay, so they are talking about extragonadal germ cell tumor, and it's involving duodenum in this case. And then there is another one, if it's too big.
So Yashant, none of these had gonadal tumors at all?
The first one had a burnt out, and the second one had,
Okay.
I think I was reading it here. Okay. So one had a testicular mass, the other one had burnt out one.
Nice.
And I found another article, which is just extragonadal germ cell tumor. And again, it's like duodenum, D3, and they have great endoscopic pictures as well. So I think it's a great teaching point that, if you see a young male, maybe in 30s, 40s, and a retroperitoneal mass, we should think of germ cell tumor also as a differential.
Yep.
Very nice. Roopa, one more question. That radiographics article, you said in the beginning they have a new classification splitting it up.
It's not new, Aarti. It's 2016. It was just new to me. So
Okay. But is there like, what's the point of like for us to know like
I
split
think
up or
from what I learned was I think the post-pubertal subtype, which I've not seen our pathologists describe it that way. I don't know if it's just an age thing or what. Those were the ones that had to come out surgically versus others. Many others could be chemo and radiation sensitive.
got it? Okay. Thank you.
This is a patient who presented for evaluation of hematuria. This is a non-GU finding that I learned about recently. Well, from this case.
Are the bowel folds
Yes,
thick?
yeah. And so, yeah, tell me about the bowel.
Like she was saying thickened folds with like fecalization inside.
Yeah.
A lot of
It's
What's the age and gender?
let's see, it's a young person and the gender is male.
And have they had prior surgery?
No
Like-
prior surgery.
Okay, I have at least 2 differentials because of
Go
the
ahead.
folds. Is it celiac or is it scleroderma?
Great differential.
I was thinking
This,
scleroderma also, the hide-boundy
yeah.
appearance.
I thought those aren't necessarily thickened, but like multiple increased number, but widened dilation.
So this is a genetic condition. So it's not scleroderma or celiac. This patient has a mutation. It's a filamin A gene mutation. And you get these findings, it turns out. So they get these GI problems. So it's a pseudo-obstructive symptoms. They get dilated appearance of the intestines. They get dysmotility. They have congenital short bowel syndrome, which this patient does have. Chronic, like pseudo-obstructive findings, constipation, weight loss, feeding difficulties. There's other multi-system findings as well, but these are some of the GI symptoms that patient can have. And it's been chronic. This has been ongoing, for a long time, and these are chronic findings.
Wow. Nelly, I was actually thinking maybe like bacterial overgrowth in your case, and which I sometimes see patients with short gut syndrome have this kind of look.
Yes, this patient does have that syndrome, like short gut syndrome, like clinically.
Yeah, but like it's interesting because I didn't know that there's such thing as congenital short gut syndrome. So that was
I see.
like they just don't even like I've seen it in patients who've had multiple bowel resections and have short gut and then dilated thickened bowel with bacterial overgrowth.
Mm.
But your case, I never even thought like you could have congenital shortcut. So it must mean, because I was actually recently just looking up the length of the small bowel, and I
Yeah.
read somewhere like it could be anywhere from 200 to 800 centimeters. And I was like, how could that be such a big range? And I guess like the 200 end would be like somebody who has congenital shortcut, you know?
That makes
But-
sense. Yeah. I mean the lengthwise I didn't notice. I mean, just grossly, like I don't know. I'm not sure if this is on the shorter end or the long, but clinically the patient has symptoms of shortcut syndrome.
Got it.
I don't know if that translates to physically like shortcut versus functionally shortcut.
Can you show your images again? Because that's why I thought
Yes.
they had prior surgery. Like it did not look to me like they had it.
Normal length. Okay, let me.
Yeah.
Never heard of this syndrome, Nelly.
My first time too. So I see, jejunum here. So I don't know. I can see
It
how
does
maybe
look
it's on the
awfully short, like Aarti
shorter
said.
end than, length.
Yeah, because the rest of that stuff on the right, it's so dilated, but there's
Yeah.
not much of it, you know?
Redundant. Yeah, there's not a lot of redundancy.
Yeah. Very cool. Okay, so ignore the bowel and focus on the retroperitoneum.
IVC.
IVC what?
I want to say a coronal.
A what?
Coronal.
Okay.
Oh, but I thought the lymph nodes look a little bit chunky,
Uh-huh.
and the IVC is ligated.
Yeah, what is it ligated by? I'm going to show you the axial again. You guys know this device?
Not seen it before, Aarti.
Okay, it's called an Adams Deweese clip, and I can pull it up. But basically, it was something used, I think, in the 60s that they would clip off the IVC. There's still these fenestrations in it, so it's kind of like before IVC filters where it became popular. And it's called an Adams Deweese clip. It's now fallen out of favor. And then there's a bunch of lymph
Did you
nodes.
say that was to treat IVC, like thrombus, like just to
Yeah.
prevent it from propagating? Oh, interesting.
Yeah, I'll pull it up actually. Hold on, let me show you. So here's an article about it. So it was like this kind of, they had one clip that was like kind of just an open one. And then this is the Adams. Oh, actually, I guess, I don't know. Oh, there's multiple different clips. Okay. Well, anyway, long story short, this one was called an Adams Deweese clip. And we called these lymph nodes and they seem to be kind of increasing over time. Any other thoughts? Anyway, this went for FNA. This is an old case, but this went for FNA and they got blood.
Are those some kind of like varices or something, Aarti?
Wow. Cloud.
Yes,
Yeah.
exactly.
Oh my gosh.
So if you look at the coronal, if you look at this more carefully, they look kind of serpiginous, right? And like really like right there, and you can kind of connect them. But what do you think would be a good problem solving for this?
Multiphasic.
Okay.
Well,
Well, we did an MRI.
MR. TOV
Yeah.
shoot. Yeah.
Because
it should be
ultrasound,
blood.
I think
Yeah.
retroperitoneum would be too deep. And then now we can see that there's like flow voids. So, so if you're ever wondering, is something like a vessel or a lymph node, the MR would be helpful. Because both can enhance and kind of mimic each other. So anyway, and then I have another one that I wanted to show. Oops. So this is a patient, my colleague was reading this, and he noticed that the urethra right here is dilated with fluid. And that there was this
It's enhancing too.
uh-huh. And that there was this kind of like foreign body here outside of the patient. And
Like pinched off by.
yeah, I'll just point out that there is a foreign body here with a metallic part to it. So when I was showing my IVC clip, he was telling me like, oh, I learned about this other kind of clip. Do you guys know what this is called? Okay, this is a Cunningham clamp. And so I'll just show you. So this is for incontinence. And so instead of having an artificial urethral sphincter, you have this sort of soft clamp that you have, and then like one side has this metallic buckle, and you put it on the penis. So it's not, it's a little bit of pressure, not too painful, and it puts pressure on the urethra and can make sure that you're not incontinent.
Very cool. Not seen this also.
Yeah, exactly. Like I told him about my Adams Deweese clip, and he's like, I just learned about the Cunningham clamp. And I was like, what the heck is that?
Yeah.
So
Wow. This is a patient, pelvic pain.
it's like adenomyosis.
Right here. So yeah, there's T2 cystic spaces, thickened junctional zone. Okay, what else?
I'd want to look at the T1 pre at that left adnexal lesion. Oh,
This is the left adnexal lesion, sagittal T1.
so it has some T1 hyperintensity in it.
Mm-hmm.
And
Yeah.
both sides, actually, both ovaries.
Yes.
So endometriosis also.
Yes. What else?
Do you think there's also stuff in the cervix?
Like where?
Well, there was just T1 hyperintense foci in the pre-contrast and the
Oh,
cervix as
sure.
well.
Here. This stuff here.
Yeah.
I wonder if these are like just pertinacious Nabothean cysts.
Got it.
That little.
Can you get endometriomas of the cervix?
I haven't seen one. You can get, like, I think the adenomyosis extends to the cervix. I haven't seen an endometrioma of the cervix, but
Okay.
endometriomas, endometriosis, deep infiltrate, they can go anywhere. So I suspect they could. Okay, what else? What do you think about this?
I was gonna say, there's like tethering of the
Yes.
ovary to the cervix and like.
Yeah, there's this T2 dark plaque here, right there, and there's a distortion, architectural distortion right here. So this is all.
Is it also tethering the rectum or sigmoid or?
Yeah, tell me about that. So let me go back. Here's the right side.
Like a mushroom cap trying to form.
Yeah, so where would you call mushroom cap or tethering?
Septum.
Oh, down here?
No, I guess not rectovaginal. Recto-uterine. Keep scrolling, Nelly. You stopped on one image.
I mean, there's that very thin line between
the band,
but then right there,
right there, exactly.
Yeah, that looks more suspicious.
Yeah, as if the muscularis is being invaded from outside in.
Yeah, good. Okay, so there's T2 dark plaque right here in the torus, and this is all deep endo on intraoperatively, and then this was also called possible sigmoid involvement of deep endo, and this was negative. There's no sigmoid involvement, and the teaching point here is these now, because of we have this bi-monthly endometriosis board where we review all the operative cases, like post-op cases, and it's been such a great educational experience. I call these things abutment now because often it just falls right off the sigmoid. The only time I call it deep endo is if there is T2 dark plaque, and when you have this T2 intermediate signal, oftentimes it doesn't pan out to be anything. So this was called possible deep endo. I mean, it's good for that. It's good and important anyways to just raise it, because then patients get a consent for possible sigmoid resection or resection. I'm sorry, resection, or sometimes they can just shave it off. Then that's part of the consent process. And if it turns out, you know, the sigmoid is fine, then it's fine. They don't have to do anything. But if there is indeed deep endo, then the patient's already been consented for it, versus having to bring the patient back for a second operation. So it's something that I think we overcall, and because of these endo board, I've called a lot less if I don't see a discrete T2 dark plaque. So this was not a deep endo, even though we had suggested it preoperatively. But this was all endo, and there was endometriosis, stage 4 endometriosis. So I mean, there's pretty extensive, you know, they do like peritoneal stripping and pretty extensive surgery to try to remove all the implants.
I like your point about the like T2 dark versus intermediate. I have a question. You know, the part that is like the thinner line that you said was tethering the rectum?
Like this, like these little guys here?
Yeah, exactly. Did they have to resect part of the rectum, or
no? Like if it's
just cut them?
yeah, like these are usually, like these are usually nothing actually. The only time when they do our gynecologists tell us like 50%. So if there is a deep endo, we tell them the circumference of the rectum. So if it's, so like, for example, let's just say there was endo here, we tell them the circumference of the rectal involvement. And if it's more than 50%, they have to do a segmental resection. If it's less than 50%, then they can usually shave it off and do a primary if they needed to. The other kind of rule of thumb is 3 centimeters. So we also tell them the length cranially that it is involved. If it's more than 3 centimeters, then they usually have to resect it. They get colorectal surgery involved. If it's less than 3, then they can do it themselves. Like they just shave it off.
Nice.
That's good to know, Nelly.
So I was talking about microlithiasis. So I just have still images here. So this guy came with microlithiasis, young guy in 30s, no lesions in the testes, like concerning for either a germ cell tumor or a burnt out germ cell tumor. Nothing of that sort was present. And then simultaneously, he also had this big deposit in the anterior mediastinum, and it turned out to be non-seminomatous germ cell tumor. Again, like that's a very rare thing to happen. So that's about it. I can show my case now.
Yashant, what prompted the chest CT?
He had cough and the respiratory symptoms.
Okay. I guess the question should be what prompted the scrotal ultrasound, because there's nothing there.
Yeah, I mean, I think
I wonder though, like if they're both kind of like of germ cell dysplasia lineage, like kind of like what Yashant was saying, like they both could be part of the same spectrum of like germ cell dysplasia, you know?
So that's what I was thinking, Aarti. So then is it worthwhile every time we look in the testicle to also look at the chest? That's kind
I
of
think
what
it
I
might
was
be
wondering.
too
no,
rare.
it's a rare thing. It's a very rare thing.
Okay.
But again, like as we know from embryology that, you know, germ cell, they reside in the midline. Like we can have germ cell tumor in the brain also, like, you know, in the midline, like around pituitary, around pineal gland, in the mediastinum, in the retroperitoneum, and in the scrotum. Because the fact that, you know, germ cell, they migrate at multiple places, and these are the aberrant places of migration. But yeah, that's rare. So, okay.
Right.
Can I begin my next case?
Yes.
Okay, this is an elderly male who comes with complaints of, this is an elderly male. He's obese, very high BMI. He comes with complaints of scrotal swelling, which has been there for quite a while. We see a lot of thickening of the skin, a lot of edema, and there is bilateral hydrocele. And I'll show you the sagittal of this.
Looks like massive localized lymphedema so far.
Absolutely, yeah. I'm showing this case not as much for the radiology findings, but for the procedure. There is a condition called as acquired buried penis. So if there is a lot of fatty deposition around the penile shaft in the pelvic area, so that can lead to burying of the penis. So the penile shaft, which is visible outside, is not as big, and it just gets buried inside. So what are the problems it causes? Once it is inside, buried inside this fat pad, the fat itself will act as a mass effect and will impede venous and lymphatic drainage. So that is a vicious cycle giving rise to all this lymphedema. Secondly, because the glans is also sort of covered here, so the patient has recurrent balanitis, which this guy also had. If we see there is this fat pad which is coming from top, this is not as big. This is called pannus. If this causes covering of the penis, the procedure that we do is peniculectomy. But if the fat pad in the vicinity of penile shaft is big and that is taken out, this is called as escutcheon. Let me show you how it looks, what I mean by that. So basically the word escutcheon means a shield, and that's how the male escutcheon and the female escutcheon look like, which means the area immediately around the external genitalia. And our patient in question underwent escutcheonectomy. And once he went escutcheonectomy, it may not look as impressive on radiology, but his lymphedema improved. And
Oh yeah, so much of the shaft is like externalized now.
Wow, but yeah, that lymphedema looks amazing. It looks like his pannus though now needs help.
yes, like
Wow.
now the shaft is outside. So I mean, yeah,
Yeah.
it does not look radiologically as impressive, but I was just
Yeah, no, it's
impressed by
interesting.
the procedure name.
Is that an English name?
I think so. Let's see.
Just curious.
I was just
Learned a
thinking
lot
it's
of new
new,
words
the
today.
new word of the day.
Yes,
Mm,
looks like it is English.
yeah, Oxford. Yeah.
Okay, cool.
Very cool. Okay, so what do you guys think about
Peribiliary cysts. Why is it on both sides? At least, no.
okay, well, keep scrolling down.
Carcinoma gallbladder.
Yeah, gallbladder looks.
Exactly. So there's a gallbladder cancer directly invading segment 5 of the liver. So it loves to directly invade segment 5 because the veins and the lymphatics drain directly in here. So that would still be localized, although it looks pretty aggressive.
Retroperitoneal nodes.
Exactly. So there's this big necrotic looking node that's actually causing obstruction of the bile duct. So I've seen this not infrequently where like you have a bad gallbladder cancer with a node and the node itself is so fibrotic that it can obstruct the bile duct. And then all of this is just upstream biliary ductal dilatation. I know it looks kind of beaded, but it's just buildo. Okay, so now we have an MRI. We've got our tumor here. Any other observations?
Are the other stones inside the ducts?
Yes, there's tons of intrahepatic
Pigmented,
bile
yeah.
duct biliary stones. So
So
all
was it
of these
PSC
here.
or parasitic infestation?
Yeah.
Yeah, exactly. So let me just show you the coronal. So tons of intrahepatic and then extrahepatic stones going all the way down. So we're like, oh, is the obstruction? I mean, I really truly think the obstruction was caused by the necrotic node, but the stones were going all the way down there. This person is from Southeast Asia, and so we think
Nice.
that they have RPC, or recurrent pyogenic cholangitis. And I actually think that's probably what caused, you know, all the system to be inflamed and dysplastic, and then probably there is a higher risk of both cholangiocarcinoma and gallbladder cancer in patients with PSC. Sorry, RP.
Wow.
Yeah.
Keep looking for cholangio. I've never seen gallbladder cancer with that.
Yeah, so gallbladder is considered like in the same kind of
Part
system.
of
So
the,
like,
yeah, makes
like
sense.
even patients with PSC have increased risk of gallbladder cancer. But
Like with
also I want to
choledochal
just point out,
cyst.
what?
Like with choledochal cyst, we have a risk of cancer of the choledochal cyst as well as gallbladder. Same with PSC, same with parasites.
Yep. And I just want to point out how bad CT is for looking for stones. So here's our CT, and we don't see any of those stones. And these are like 2 days apart. So most gallstones are cholesterol stones. They don't have calcium in them, so they're not necessarily dense. So we often don't see them on CT. So just a case of gallbladder cancer in the setting of recurrent pyogenic cholangitis.
It's interesting to know that we have three different types of liver flukes. One is fasciola, which just causes cholangitis and no cancer. But then we have two other types, which is CO, C for clonorchis and O for opisthoarchis. And these two do not come alone. They come in pairs, and what they come with is cancer, which is cholange.
Interesting.
And the way I remember it as, like, the names are very pretty mouthful, clonorchis and opisthoarchis. So I remember it as CO. CO also in English means something coming along, like conjoint. So they come with something, and that something is cancer. Whereas fasciola is just cholangitis, no cancer.
Nice. And then what about ascariasis?
Ascariasis is not associated with cancer.
Okay.
Schistosomiasis is associated with HCC and urinary cancer. Even hereditary I don't think is associated with cancer.
Okay. And then you say schisto, though, there's different types, right? Hematobium is in the bladder first, so that's associated with bladder cancer, whereas japonicum and Mansoni are in the liver.
Yeah, japonicum and Mansoni are for liver,
Yep.
and both are associated with HCC. And the newer case reports describe an association, not causation, of these two types with lymphoma also.
Wow.
But it's not it's not a causation. It's just an association.
Got it. You are a parasite expert.
And not like you. Thank
No,
you.
no. Okay, Nelly has a case.
Companion case from the other case. So this is pelvic vein, known history of endo. Oh my goodness, what's going on? Let's see. Okay, so post hysterectomy for endometriosis, and is symptomatic, has recurrent symptoms.
Looks like bowel is dilated. And then what's the top, like, is there fluid affiliated with the top of the vaginal cuff?
Let me give you the T2 Sag. So here's the cuff. There's bowel on top of the cuff. And then I think the T1 is helpful. See if I can get the T1.
Nelly, the top of the cuff looks thickened also.
Yeah, right there.
It's T2 hypointense.
Okay, here's a T1 pre.
Like a nodule along top of the
Like right
cuff.
here.
Yes.
Yes. So I think is it this one here? Yeah. So yes. So this was proven to be deep endo, nodular endo. There's another finding.
I don't like that dilated bowel loop.
This one up here?
Yeah,
Small
like
bowel?
Yeah, the bowel above it is like completely collapsed, and then that one looks really dilated. So I'm wondering if it's like there's a partial obstruction or a closed
Yeah,
loop
let's see.
related to endometriosis.
Well, the small bowel was okay. I want you to focus on the rectum, rectal sigmoid.
In the pre-sacral area, is the wall of the rectum very thick?
Yeah.
Like here,
A little more posterior.
posterior, like here,
Other side.
here.
To the,
Yeah.
yes, is that a segmentally thick?
So this was okay. There was endo here. This is all deep endo right here. And I'm showing this case because deep endo, you can see them but you have to, that's dark. It's dark. It's too dark like this. And there's cystic spaces here, a little bit here, a little bit here. And this is all deep endo. And with deep endos, they retract, right? It pulls it in. And so there's Maria Zulfikar wrote a paper. They call this a cookie sign because it's, I mean, not cookie. What do you call it? Fortune cookie sign. Fortune cookie sign. Typically up in the sigmoid because it's a little bit more floppy, and with the sigmoid mesentery, whereas the rectum is more fixed. You see more of the mushroom sign because there's not really much for it to contract or fold, whereas the rectum is more floppy, so it can kind of fold in where the deep endo the invasion, the implant is like kind of invading into the wall. So it's all here, right there. That's all deep endo.
And did you see any T1 pre brightness?
Let me pull the T1 pre. I find that the T2 is actually the most helpful for looking for deep endo. I don't find T1 very helpful for deep endo. It's very good for implant, like endometrial implants and stuff, but for deep endo, I think T2 is the best sequence. Let me co-localize it. So it's right here. So it's right there. This. So yeah, maybe
Oh, there
here.
are little, yeah.
Yeah, right there where the T2 stuff was, maybe.
And then all the rest of it that was dark is like this kind of grayish.
Yeah.
Yeah.
So right there. Yeah,
Nice.
the cystic thing is bright. Yeah.
But isn't it difficult on T1 at times because how do I know
Poop,
that's
yeah.
not in the bowel lumen, because fecal material at times is T1 hyper.
Yep. Yeah, I agree with that. Yeah, that's why I
think
think
it's just like
T2
a
is the best.
secondarily confident thing, not like a primary thing.
Yeah, yeah.
Also, this is within, like it looks like in the wall of it, right? The lumen in this case is seen a little separately, so that's
Okay.
very cool.
Wait, hold on. Oh, like along the wall instead of within the lumen. Is that what you said?
Yeah,
Okay, yeah. I see what you're saying. Yeah. So this was it was like an almost 3 centimeter segment of deep endo that they had to resect that. It's right there, yeah. So it's visible on MR. You just have to kind of be keen on it and find it.
You are our endo guru.